Good morning, everyone. Today we are discussing about dental caries, in which we are covering following topics: contents, introduction, definition of caries, history, epidemiology, classification, etiology, theories of caries etiology, old theories, exogenous theories, endogenous theories, and the current concepts. Introduction: common chronic disease. Second, multifactorial etiology. Third, present in all geographical areas. Fourth, trend peaks and then begin to decline in 1970s and early 80s, attributed to the addition of the trace amount of fluoride, iron in public drinking water. Definition: what is caries? According to the Latin, rot or decay substances, process of enamel and the dental dissolution that is caused by microbial action at the tooth surface and is mediated by the physiochemical flow of water dissolved ions is called caries, given by the Ostrom in 1980. Dental caries is an infectious microbiological disease of a tooth that results in dissolution and destruction of the calcified tissues, which is given by Sturdivant, according to whom 1993 caries is essentially a progressive loss by acid dissolution of a appetite component of the enamel or the cementum then dentine. According to the Schaeffer textbook of the oral pathology, dental caries is a microbial disease of calcified tissues of the teeth characterized by the demineralization of inorganic portion and destruction of organic substance of the tooth. History: evidence of caries present since ancient Indus Valley civilization, described in Mesopotamia, China. According to FASS 1962, published the first comprehensive description of caries tooth decay in infants, which is termed nursing bottle mouth. Epidemiology: according to WHO report 2003 states, caries is considered a major oral health program in most industrialized countries, affecting 60 to 90% of school-aged children and the vast majority of adults. The Center of Disease Control and the Prevention (CDC) April 2007 trends in oral health status reports indicates Americans of all ages continue to experiences improvement in oral health, except tooth decay in baby teeth increased in children aged 2 to 5 years from 24 to 24 to 28% between 1988 to 1994 and 1999 to 2004. Incidence or prevalence: dental caries in India, consequently increasing prevalence and severity, especially in children. First National Oral Health Survey planned in 1984 by IDA with commitment to achieve WHO goals in our country. Prevalence, which is 54.1% 3 to 5 years, 22.3% 12 years. After age 24, DMF starts declining because of build up of fluoride in outer layers and change in dietary habit. Other factors: according to the Meshler, age 3 years, which is peak, and in between 4 to 8 years, 11 to 19 years, and 55 to 65 years, female are more affected by caries than the males. Race: European, North America high, African, Asian, Aborigines is by low. Familial: children of parents with the high caries have higher incidence. Time factor: incidence of caries highest 2 to 4 years post eruption of the teeth when it decreases. Classification of dental caries: According to the anatomical location on the individual tooth, pit and the fissure caries, which is present mostly on the posterior tooth, smooth surface caries, root cementum caries, classification based on the severity and the rate of the caries progression. First of all, incipient or the initial or primary caries lesion, recurrent secondary caries, acute or the rampant caries, arrested caries, active caries, or the residual caries. These are the types of the dental caries according to rate of caries progression. Based on the number of surface involved, in which how many surface are involved of the tooth by the caries. The first of all, which is simple caries, that involve only one surface of the tooth, like occlusal surface, mesial surface, distal surface, palatal surface. Compound caries that involve two surfaces of a tooth, like mesoproximal caries, distal proximal caries, buccal proximal caries. These are the caries which is involved. It's called compound caries. Third type, which is complex caries, which involve more than or three or more than three surfaces of a tooth, according to the rapidity of the process. Acute dental caries, chronic dental caries. These are the type of caries according to the rapidity of the process. According to whether lesion is new one attaching a previously intact surface or whether it is occurring around margins of the restorations. Primary virgin caries, secondary recurrent caries. On the basis of severity, mild, very mild caries, moderate caries, severe caries, very severe caries, which is also known as the rampant caries. Based on the chronology, early childhood caries. According to the chronology, based on the chronology, there is a first type of caries which is known as the early childhood caries, which is present in the infants, newborn babies, like nursing caries, rampant caries, linear enamel caries, also known as odontoclasia. Teenage caries, adolescent caries, or adult caries. These are the caries which is present according to their ages. Based on the pathway of caries, forward caries or the pit decay, backward caries or the smooth surface lesion. These are the caries of based on the pathway. TV Black classification. It is a therapeutic classification. It is based on the treatment and the restoration design. Class 1, pit and the fissure cavities that occur in the occlusal surface of the bicuspid and the molar. The occlusal two-thirds of the buccal and the lingual surface of the molar and the lingual surface of the incisors. Also known as the class 1 caries. One more time, class 1 caries are the caries which is present in the pit and fissure caries that occur on the occlusal surface of the bicuspid and the molar, the occlusal two-thirds of the buccal and the lingual surface of the molars and the lingual surface of the incisors, also known as the class 1 caries. Class 2 caries are the single proximal surface of the bicuspid and the molars. Class 3 caries, cavities in the proximal surfaces of the incisor and the cuspids, not involving in the incisor angles. Class 4 caries, cavities in the proximal surface of the incisor and the cuspids involving the incisal angle. Class 5 caries are the gingival third of the teeth, all tooth. Class 5 caries present, which is cavities in the gingival third of the all teeth. Class 6, cavities on the both mesial and the distal proximal surface of the bicuspid or the molar that when restored will share a common occlusal isthmus or the cavity on the incisal edge of the anterior and the cuspid of the posterior tooth. Based on the histology of the caries. Based on the histology of the caries, which is caries of the enamel and the caries of the dentine. Now we are talking about the etiology of the dental caries. Theories of the caries etiology. First, early theory. Second, exogenous theory. Third, endogenous theory. And the current concepts. Legend of the worm, which is 5000 BC. Earliest reference of the tooth decay and the toothache came from the scientist Sumerian text, the legend of worm. Discovered by the clay tablet, 5000 BC. Early history of the India, Egypt, and the writing of the Homer also makes the reference of the worm as cause of the toothache, caused by the worm, drank blood of the teeth, and the fat on the root by the jaws. Humoral theories given by the Galen stated that dental caries is produced by the internal action of the acid and the cautery humor. Four elemental humor of the blood were blood, phalgum, black bile, and the yellow bile. Diseases are due to the imbalance between them. Hippocrates favored the concept and referred that stagnation of juices in the teeth was the cause of the toothache. Vital theory. Vital theory. Advanced towards end of the 18th century, postulated that tooth decay originated like bone gangrene from within the tooth itself. Internal resorption seen in some tooth. Internal resorption seen in the subtooth. Chemical acid theory given by the Robertson in 1835 proposed that dental decay was caused by the acid formed by fermentation of the food particles around the teeth. Fermentation was discovered non-vital process till this time. Organic acid implicated, microorganisms not thought as cause. Parasitic septic theory. Iridral. Parasitic septic theory, which is given by the Iridral in 1843. Postulated microorganism can have toxic effect on the tissue. Dubois, 1954. Anthony van Leeuwenhoek, 1832 to 1723. Filamentous parasites present on the tooth surface were caused by caries process. Ficus called dentocola. Chemicoparasitic theory, which is also known as the acidogenic theory. Acidogenic theory, which is given by the W.D. Miller, was the first who well-known scientist and the investigator of dental caries and published his result in 1899. According to him, dental decay is a chemoparasitic process. It is a two-stage process. It is a two-stage process uh, in which there is a decalcification of the enamel, which also results in the destruction of the dentin. In the second stage, there is a dissolution of the softened residue of the enamel and the dentin. In the first stage, there is a destruction of the done by the acid attack, whereas the dissolution of the residue is carried by the proteolytic action of the bacteria. The second, in which the whole process is supported by the presence of the carbohydrate microorganism in the dental plant. Miller was the first to link caries to triad of oral microorganisms, which is also known as the multiple microbes, carbohydrate, substrate, and the acid, lactic, butyric, acidic, and the formic acid. Tooth host. Three aspects of the tooth to be considered. The first of all is composition. The second is the morphologic characteristics. The tooth size. According to the Hunter, 1967 studies size of the teeth in relation to the post-caries experience. Teeth that has been restored were larger than the untreated caries-free teeth. This implies a larger teeth were more caries susceptible. Pentner and the Gagner in 1962, overall dimensions of the teeth are smaller in size with the water fluoridation. Studies by the Carvalho et al. 1989 indicated that de novo plaque reaccumulation over 48 years, about 5 minutes later in the fissures of the erupting molars than in fully erupted molars, particularly in the distal and the central fossa. This explains why almost all fissures caries in molars is initiated during the long eruption time, which is 12 to 18 months. Fissure pattern of the permanent molar caries. Fissure pattern of the permanent molar varies with the racial group. Some teeth have deeply convoluted fissures prone to caries, which is given by the Taylor, 1978, agent. Microflora. According to the microflora, mouth. A wide variety of the oral bacteria which is present in our mouth. Specific species of the bacteria cause dental caries. Streptococcus mutans and the lactobacilli, isolated by the Clark in 1924. Bacteria collect around the teeth and the gums in the sticky, creamy colored mass called plaque, which serves as the biofilm. Some sites collect the plaque more commonly than others. Streptococcus mutans, an acidogenic and the acidic microorganisms colonizing the oral cavity, is considered to be main cause of the dental caries, which is given by the Luce in 1986. Bacteria capable of producing dental caries, like species or the genus. A species is Lactobacillus and the Streptococcus, and the genus Lactobacillus acidophilus, Streptococcus mutans, Streptococcus soberanus, Streptococcus sanguis, Streptococcus salivarius, Streptococcus mitis, Streptococcus miliarii, Streptococcus facilis, actinomycin viscosus, actinomyces israeli. Ecology. Streptococcus mutans, which is gram-positive, non-motile, facultative, anaerobic, was isolated from the human caries teeth by Clark in 1924. In a single human mouth, there often are more microorganisms than there are people in the entire world. By the time our infant reaches adolescence, the mouth will harbor more than 400 microbial species. Colonization of S mutants take places after eruption of the teeth. Frequent contact, parents plus others. Mother who share food, drinks, utensils have high risk of transmitting MS to their children. Produce acid lives in acidic environment and sticky polyacroside dectrine. S mutant does not spread radially from one tooth surface to another. Colonizes the teeth. Laushi et al. 1979 strains of the S mutants artificially implanted into fissures on one side of the mouth did not spread to the explorer. Dental explorer or the floss often contain 10 to the power 6 S mutants, which is Streptococcus mutant cells. Other plaque bacteria associated with the caries, lactobacilli. In 1915, Liger reported the presence of the higher numbers of the lactobacilli in the caries region than in the non-caries site. Lactobacilli are known to the favor of the dorsum of the tongue, while the Streptococcus mutans requires a solid, non-shedding surface for the colonization. Appearance of the S mutants in the mouth of the toothless infants, where the obturators are inserted to the fixed cleft palate, was seen by the Tenzer and the Livingstone et al. In 2001. Actinomyces are the pleomorphic gram-positive rods, may be anaerobic, microaerophilic, or the facultative. These have the ability to produce PDL destruction at the root surface carry. Actinomycillus viscous and the A. have this potential. Sucrose are criminals. Low molecular weight sugars like the sucrose diffuses radially into plaque and the metabolized by the bacteria. Sucrose is much more carcinogenic than the glucose. Sucrose is more abundantly used sugar in the modern diet. Energy liberated from the ruptures of the disacchyloride bond of the sucrose is utilized by the synthesized glucans. Water-insoluble glucans have also been found to lower the calcium and the phosphate concentration of the saliva, decreasing its ability to repair the tooth decay caused by the bacterial lactic acid. Napiogoma Camia et al. In 2004. Gabbans in 1984 done a study in which all sugars differ little in acidogenic potential, synthesizes extracellular glucans, which is water insoluble and enhances accumulation of these streptococcus mutants. Substrate fermentable carbohydrate plus plaque, acid formation, demineralization of the enamel, plaque bacteria plus substrate, which is acid production, rapid drop of the plaque in pH with the sugar containing food causes demineralization of the sugar enamel. Dental enamel. Sugar studies. The amount of sugar eaten is not as important as the way it is eaten. Sticky sugar produced consumed tend to be retained on the tooth than the liquid form. Sugar consumed in between the meals has been much greater potential than consumed during meals, according to the Gustafson et al. In 1954. Heredity fructose intolerance, which is HFI. In 1959, French scientist Froech transmitted as autosomal recessive gene ingested of the fruits containing fructose or the cane sugar. The fructose tolerance test showed marked hypoglycemia, rise in the blood fructose level, serum phosphate level which is low, person with HFI, 50% population are the caries free but not detailed enough to express DMFT. Carbohydrate intolerance and the dental caries. Intolerance to the disaccharide or the monosaccharide occurs because of the deficiency of the certain enzymes involved in the metabolism of the sugar. Conditions known as hereditary fructose intolerance provides direct link between the sugar and the dental caries. Drawbacks of the Miller's acidogenic theory. Smooth surface caries was not accounted. Phenomenon of arrested caries was not explained. The reason that's why certain population are the caries free was not explained. No attempt done to a certain type of the microorganisms. Proteolytic theory. Proteolytic theory Gottlieb in 1947. The evidence given by the acidogenic theory was considerable, but it is not conclusive. What not conclusive, an alternative explanation was given in the form of the proteolytic theory. Workers like Heather Bodecker and the Abbott contributed considerably to this theory. There was often evidence that the organic portion of the tooth plays an important role in the development of the dental caries. There are some enamel structures which are made of the organic material such as the enamel lamellae or the enamel rods. These structures prove to be the pathways for the advancing microorganisms. It has been explained that the enamel contains only 1 to 1.5% of the organic matters, of which 1.8% is keratin and the 1.7% is the soluble protein. Microorganisms invade the enamel lamellae and the acid produced by the bacteria cause the damage of the organic pathway. According to this theory, organic part removed first, then the inorganic component is removed. Drawbacks of the proteolytic theory. Enamel is highly structural tissue. It has 1 to 1.5% of the organic matrix, where the protein is 0.6%. Initially of the carries by the breakdown of the such small percentage of the protein is questionable. Sulfates of the gram-negative bacilli are not formed. Enzymes such capable of attacking keratin was not formed. Proteolytic chelation theory, proteolysis chelation theory. Some of the minor flaws of the acetogenic and the proteolytic theory was addressed in the proteolysis chelation theory. This theory was put forward by this Stretch in 1955 and his co-workers. Proteolysis chelation theory, Stretch and the Martin 1955. Chelation. It is a process in which there is a complexing of the iron metals to form the complex substance through coordinate covalent bond, which results in the poorly dissolved or the weakly ionized compound, and which are small still soluble. Proteolysis chelation theory. Chelation is independent of the pH of the medium. Bacteria's attack on the enamel, initiated by the keratinolytic microorganism, results in the breakdown of the protein, chiefly keratin, and the results in the formation of the soluble chelates, where decalcifying enamel even in the neutral pH. Mucopolysaccharides are also act as the secondary chelators. Bacteria, which is going through organic matrix of the enamel, proteolysis first, then release of the chelators, example, citrate glycine, then binds with the calcium phosphate of the enamel, then formation of the calcitrate, calcinate soluble removed, then demineralization secondary carries. Drawbacks of the proteolytic chelation theory. Enamel has small amount of the organic component. Its dissolution to produce chelates and the disintegrating rest of the 96.6% inorganic contents are considered doubtful. Sulfatase theory. Pincus in 1950, bacterial sulfatase hydrolysis, which is two types. Mucatin sulfate of the enamel, chondrotin sulfate of the dentine, in which sulfuric acid then gone through the decalcification of the dental tissue, complexing and the phosphorylating theory. Lurine 1967, uptake of the phosphate by the bacteria caused during the glycosis. Local phosphate equilibrium disturbed. Loss of the inorganic phosphate from the enamel. Soluble calcium complexing compound formed. Drawback: saliva is an abundant source of inorganic phosphate for bacteria. Therefore, efficiency is less likely. Autoimmune theory. Rutch and the Jackson, which is given in 1970, suggested genes partially inherited and the partially mutational determines whether a site of the tooth or it is risk or not. Odontoblast cell at specific site get damaged by the autoimmune mechanism. Enamel and the dentin is compromised, resulting in the cavitation. Drawbacks: Jenkins pointed that most data in this theory based are the epidemiologic. It is doubtful whether these data collected are more sufficient, accurate or not. Current concept. Demineralization. Mineral concept of the tooth surface. Hydroapatite crystal is an equilibrium with the neutral environmental saturated with the calcium and the phosphate. Reactive to the hydrogen ion at crystal of 5.5 pH, H plus ion react with the phosphate in the aqueous environment. Hypophosphate not able to contribute to the normal hydroapatite crystal. Process termed as the demineralization. Demineralization process of removing mineral ions and the dental enamel. Bacteria attach to the layer of the glycoprotein coating enamel and create acid from the food sugar. The acid produced by the bacteria, mutant streptococcus and the lactobacillus can enter and dissolve to the tooth underneath the panicle. First sign of demineralization is the white spot. Remineralization. Reverse of the demineralization. If pH is neutral and sufficient calcium and the phosphate ions are present, this leads to the rebuilding of the partially dissolved apatite crystal called the remineralization. Remineralization is counteracts the damage done during demineralization. When conditions at the tooth surface are stable, acid is neutralized, a remineralization process can take place. Calcium and the phosphate in oral environment reincorporated into the tooth, reversing the damage done during the demineralization. Saliva buffer the acid and produce the minerals necessary for the remineralization. Enhancing remineralizations by the fluoride applied in the incorporated in the new tooth surface. Process will continue until the repair has been completed or until bacterial acids change condition or to favor demineralization. Remineralization cycle 6.86 hydrogen ion react with the phosphate ion in saliva and plaque. Demineralization hydrogen ion dissolve, phosphate ion forms in presence of the fluoride. Fluoride ion and hydrogen dissolve. Remineralization phosphate ion. If hydrogen ion exhausted or neutralized air and all ion retained. Primary factors is key 1960 multifactorial etiology interaction among factors triad of the host tooth agent microflora substrate carbohydrate. Primary factors newborn 1982 caries tetralogy time added time the frequency of which tooth was exposed to the cariogenic acidic environment affect the likelihood of the caries development. During every exposure of the acidic environment, portion of the inorganic mineral content at the surface of the tooth dissolved can remain dissolved for the 2 hours. Since teeth are vulnerable during these acidic period, the development of the dental caries relies heavily on the frequency of the acid exposure. The clinical evidence implicating frequent consumption of the sugar in etiology of the caries is much stronger than evidence supporting belief that caries can an infectious disease caused by the mutant streptococci. Secondary factor, after progression of the caries, modulated primary factors, flow chart, you see the flow chart of the modulated primary factors. Consumption of saliva, iron, calcium, hydrogen, carbon dioxide, chloride, fluoride, phosphate, etc. Organic constituent like carbohydrate, glucose, lipid, enzymes, amylase, maltase, trypsin, oxidase, pH. The pH of the saliva is determined mainly by the bicarbonate concentration. The bicarbonate in the saliva is able to diffuse into the dental plaque to neutralize the acid formed by carbohydrate, the microorganisms. Action saliva with respect to the caries at its role in the removal of the bacteria and the food debris from the mouth. Continuous bathing again suggested that the environmental agent influences the state of the oral health of the person. Provision of the environmental saturated with the calcium and the phosphorus. pH of saliva. A low salivary pH flavors with the growth of the acidic microorganism, lactobacilli, streptococci, and the yeast. Alkaline pH required for the remineralization of the teeth. Buffer capacity in the low caries individual is less compared to the high caries. pH of saliva is environmental factor which influence the initial of the caries. Higher the flow rate, the faster the clearance, according to the Mural et al. In 1991, and the higher of the buffer capacity, which is given by the Brackett and the Hentzy in 1989. Primary mechanism of the caries formation. Cariogenic plaque plus local substrate equals to organic acid. Organic acid plus the tooth minerals, loss of the enamel. Demineralized tooth with bacterial cavitation, proteolytic enzyme. Reference. Stuyvesant, 6th edition. Dental caries, evident kid. Understanding dental caries, Jordan, Nicky Fraud. Correct. Dental caries, LM Silverstone. Pediatric dentistry, Levard. Textbook of oral pathology, Sheffer. Textbook of periodontics, Shobha Tandon. The chelation and the putylisis chelation theories of the dental caries, their origin, evolution, and the philosophy. Albert Sketch, dental caries in the second millennium. Abbott Ismail, Hannah Lesson, Journal of the Dental Education, 2001. The paradigm shift in the ideology, prevention, and the management of the dental caries, its effect on the practice of the clinical dentistry. Art Stewart H. Hell, Journal of the California Dental Association in the March 2003. Thank you so much, guys.